Uh, Good evening, everyone. I know it's a little bit late and everyone is exhausted, but really I'm happy to be here with the GIS again, which is I consider one of the most fruitful meetings that I attend or contribute in. And also I want to thank the organizing committee for choosing Bahrain this year to have this meeting and for amazing efforts since the morning till now. Not to make it more late, the topic of this lecture is left main coronary artery dissection. And as we all know that the left main is main as the name, it's the main artery supplying most of the LV and part of the RV also, if the left system is dominant. And a dissection is a flap that appear in the intima, causing two layers. One of them is the false lumen, and the other one that is the true lumen. The problem that the expansion of the false lumen can compress the true lumen, leading to reduction in the myocardial perfusion and myocardial infarction with left main. It can cause cardiogenic shock or sudden cardiac death. There is multiple causes of left main dissection, like SCAD, spontaneous coronary artery dissection, and or iatrogenic, or type A aortic dissection extending into the left main, or as a complication of aortic valve surgery, or sometimes TAVI, very few, but it can happen, or severe chest trauma. The SCAD, it usually happens with no obvious cause and predominantly in younger females, rather healthy before, and with no risk factors of atherosclerosis. The common risk factors for SCAD is fibromuscular dysplasia or hormonal fluctuation with pregnancy or postpartum period. Extreme stress also can cause this, either physical or emotional. Connective tissue disease like Marfan syndrome or Ehlers-Danlos syndrome, or extremely high blood pressure. For SCAD, there is a special management. Usually it's a conservative, but with left main, it have a very special situation. If it's isolated left main, you can stent it. But if the SCAD extends into LAD or LCX or both, it is better to be referred to CABG. The second most common cause, or one of the commonest cause, is iatrogenic left main coronary artery dissection. And the causes is mainly a non-coaxial guiding engagement, deep guiding engagement, or extra using extra backup guidings or amplest left guiding, especially if the left main is unhealthy, forceful injection of contrast, and especially if you're using a mechanical injector like assist device. If you're having a diseased left main, maybe it's not significant, but you need to reduce your PSI at that time. Sometimes it happens due to biased wire with rotor, especially if you're treating the LCX. It can happen with polymeric tip guide wires or CTO guide wires, and forceful push of equipment like balloon and stents or guide extension. So classification of left main dissection according to the National Heart, Lung, Blood Institute It is 6 types. Type A and B are mainly confined. A is confined dissection to the left main. B, you have a clear slit of the artery, having 2 channels that you can recognize. And both of this, they say that it can be managed conservatively. From type C to type F, it all must be managed either by PCI or by CompEdge. And type D is a spiral dissection, and type F when you have no flow in both vessels, the LAD and LCX. This more simplified classification, which type 1 is a localized dissection of the left main, and is the most common. The second type is the zipper shape type, where the dissection extends into the major branches, one or both of them. And the type 3 is extension back to the aortic root. And in type 3, the mortality is much more. So management of left main coronary artery dissection according to this publication was for type A and B. It's either stenting if you don't feel comfortable, but you can wait for 5 to 10 minutes, and if there is no extension of the dissection, you can put the patient into glycoprotein 2B3A, which really, is from my point of view and experience, it's really not safe. You will not be feeling easily to sleep in the night. From type C to type F, if you can wire the vessel, you can use, you can do PCI, and if you cannot wire the vessel, then you have to send them for CompEdge, keeping in mind to try to maintain his hemodynamics at that time, either by mechanical support, mechanical hemodynamic support. Usually that's what happened with ECMO. So this is a case presentation where we can go through the types of dissection. This patient is 67 years old, male patient. He's not having any angina, but he's diabetic hypertensive with chronic kidney disease on dialysis. The week before, the patient started not tolerating dialysis and having chest pains during dialysis. So nephrology referred him to us. The right coronary showed severe mid-segment calcific stenosis, and the left coronary we have left main that is quite healthy, and the LAD shows severe proximal lung stenotic lesion, and the LCX non-significant lesion except the OM2 showing subtotal occlusion. So we, as usual, we consulted the surgeons, and the decision was to go for PCI to LAD to make the dialysis they can do the dialysis for the patient safely. So I tried to, wiring was quite easy, tried to push to cross with the OCT, it did not cross. And so we said, okay, we'll do a 2O non-compliant balloon in this proximal lesion, and after we have done the OCT, and the OCT shows significant calcification in the proximal LAD, more, and it's very deep also, but there was a flap of dissection distally. So we said we'll go with a shock wave, and it was a very straightforward shock wave, non-compliant balloons, 2 stents in the LAD, and the result was very good. And then in the final injection, this was injection, and we couldn't re-engage the XP guiding catheter again. So immediately we changed to a Jotkin left guiding catheter. And here you can recognize that there is some haziness as ostium of the left main. Usually, coder views are not the best views to judge the left main. So I said, okay, we'll take another shot in the PA cranial with a 10 LAO to see the left main. And that's what happened with the second injection. And as you can see, so who will give this like type, which type according to the NLP? It's type E, F, or D? Any comments? Okay, for me it's a type F because there's no, it's total occlusion of both vessels. The most important at this point is not to inject anymore and try to wire very fast, and that's what happened. Thank God the wires went very smoothly, and once the wires were there, we had a flow, and then I use an IVUS catheter just to check for both the LCX and the LAD to check the extension of the dissection. And it was mainly extending from the left main into the LCX, sparing the LAD. So immediately we use a 3.5 by 28 sky point stent, so we can post dilate it up to 5.5. And pot was done, and as usual, recrossing, opening the side branch and to the stress to the LAD. We've done IVUS to the LAD. There was no dissection in the LAD, so we just done drug-coated balloon to the LAD, and this is final IVUS. Interesting in this IVUS, here it looks okay, but in the IVUS, I want to show you there was a hematoma in the left main here, extending to the ostium of the left main, but not extending to the aortic root. But anyway, we ordered CT after just to make sure. So to wrap it up, left main coronary artery dissection is one of the most serious and life-threatening situations in the cath lab, and as any complication, the best way to manage it is to avoid it. Be very gentle with your guiding, try to be as much as coaxial as possible, and avoid forcible pushing of the stents, and the management is either PCI or CompEdge. But the most important, because these patients crash very rapidly. If this happens, call for a second hand to start arranging for an ECMO or an Impella. If the patient start to be hemodynamically unstable, ECMO is the best if you're sending for CompEdge or Impella for PCI. And once you have our suspect left main dissection, don't inject, try to wire, use an IVUS immediately. IVUS is a preferred modality for left main, not OCT, because OCT we have to inject, and to confirm diagnose and put your treatment strategy, and try to stent as soon as possible. And God save us all from this kind of complications. Thank you.
Excellent.